Hola, muy buenas tardes.
Good afternoon, good morning to all of you from different parts of the world. On behalf of the IAS Educational Fund and on behalf of the API, Pan American Infectology Association, I welcome you warmly. I am Dr. Robert Paulina. I will be the moderator for this session where the theme is let's focus on what is important, key populations and the next generation. We have invited several professionals from different regions and countries to talk about different issues, and you will have a chance to interact with them through at the Q&A session. I will mention some housekeeping rules now. Currently, all participants are muted. You won't be able to unmute yourselves. Please notice there is simultaneous interpretation into English and French and Spanish, which is available for all remote participants. You may select the language you want to listen to for the presentations and the Q&A session. Those of you who are live with us in the Dominican Republic, the sessions will be available in Spanish, and I invite you to log in virtually to introduce yourselves, to get to know one another, go to the chat window, and in the interaction box, which is just below or at the bottom of your screen, you will be able to see a message. You will be able to introduce yourselves. You will be able to write your name, your organization you work for, and the country where you are. This is also a very good opportunity to get connected and to get to know each other. Please use the same chat box during the Q&A session that will take place right after our presentations. And you are also welcome to send your comments through that chat box. We would like to thank VIIV Healthcare, Merck Sharp and Dohme, and Gilead Sciences for their support for this virtual meeting and for making this meeting possible. As an active participant of the IAS Educational Fund Latin American Caribbean Symposium, you will have the opportunity to receive a one-year IAS membership at no extra cost. This will be for free. The membership will be activated once you have filled in the post-symposium survey, and once you have ticked the box in the survey requesting the membership at the very end. If you are already IAS members, the existing membership will be extended for 1 year. Please note that this symposium is CME accredited, so you will be able to get your certificate after the symposium by writing an email to iasedu@iassociety.org. I will briefly introduce some of the speakers. We would like to tell you that, unfortunately, Dr. Carlos Rodriguez Diaz will not be lecturing today due to some technical issues which didn't allow him to participate virtually. So he has apologized for this. And there is also another slight change in the agenda. I will have a presentation as well as my great friend Ivan and Dr. Willie Dunbar. I would briefly like to introduce the first speaker, Dr. Willie Dunbar. He is a researcher. He's a research fellow at the AIDS Prevention Program for the Department of Health Promotion and Disease Prevention at Florida International University. He is currently working in the design and evaluation of interventions of behavioral studies targeting marginalized groups and populations of minority individuals disproportionately impacted by the HIV epidemic. As an expert in infectious diseases, he got his PhD in public health at Université Libre de Brussels, Brussels Free University in Belgium. His doctoral research analyzed the impact of stigma and discrimination and on the linkages across the continuum of care for HSH and through a realist theory-based approach. Before joining the FIU, Dr. Dunbar was the coordinator of the HIV program at GAISCO in Haiti, and he is going to talk about the following topic: men who have sex with men in Haiti, Latin America, and the Caribbean. Dr. Dunbar, welcome. The floor is yours.
Good day, everyone, and thank you for being here to the symposium in order to discuss key matters on HIV in Latin America and the Caribbean. I am really delighted to participate in this symposium in order, as I said before, to share knowledge, to discuss on key issues and take actions for these regions. My name is Willie Dunbar. I am an infectious diseases specialist with a PhD in public health sciences. Currently, I'm a research associate at FIU and also a visiting scholar at Université Libre de Bruxelles. But before, I worked at GAISCO centers in Port-au-Prince, Haiti. So my presentation will be about HIV among MSM in Latin America and the Caribbean. As a plan, I will follow this outline: the epidemiology of HIV among MSM, some factors underlying the HIV epidemic, regional and national responses, persistent challenges, and the conclusion. In terms of epidemiology of HIV among MSM in these regions, as we can see among the data, more than 2.2 million of people is living with HIV over there. And the prevalence for the Caribbean is 1.1%, and for Latin America is 0.4%. And as we can see, 61% of people, more than 60% of the people infected are on antiretroviral treatment. And if we compare those data with the prevalence among MSM, there is a variation between 1.2 and 30.6% in the Caribbean and Latin America. And then for the new infection in Latin America, MSM accounting for 41% of them in 2017. And for the Caribbean, MSM accounted for nearly a quarter. Highly quality data on HIV prevalence among MSM in this region is highly limited. It is because of they use specifically convenient sampling with very small samples, and also there is a limited information regarding the subgroup. And nevertheless, we can see that important steps forward in countries that obviously had no previous data about HIV among MSM. And also, we are interested in the continuum of HIV services. And as you can see among the analysis, this is less than optimal. In terms of factors underlying the HIV epidemic among MSM, several factors influence the epidemic among MSM, but stigma and discrimination underlie the social vulnerability in driving the epidemic, and those factors play a central role. It is mandatory also to catch the social construct of heteronormativity, which leads to gender roles during the developmental histories of MSM. This also reinforces rejections, ostracism, and discrimination. And when we come to the heteropatriarchy concept that is central to this region, it has been shaped by a history of slavery, colonialism, and also a post-emancipation nationalisms. And this also reinforced enacted, internalized, and also perceived stigma. Stigmatized also by religious and social norms, MSMs, it is difficult for them to live in the society and also to access care. Adoption of socially acceptable heterosexual life sometimes lead to a bridge to HIV to the general populations. And also, we know about violence towards MSM perpetrated at the community level, but also overlooked by police forces. And we have limited access to prevention toward MSM. Counseling and testing also are limited, and care of treatment. So the problem is based for confidentiality. Sometimes the subgroup, the MSM, they're afraid of going to the hospital and to other healthcare services, so they can be, because of confidentiality problems. And also, we have recorded during our researches some attitude of healthcare providers that are stigmatizing towards MSM. Regarding to the pandemic, the COVID-19 pandemic, we can see that those factors are reinforced during the pandemic. And we have recorded violence and also disparity, more disparity for access to care. Discrimination are also extracted that has exacerbated, and this has an impact on HIV services. So we need to develop better tools for sexual minority during this time of pandemic, and also to get ready for potential next pandemics. In terms of regional and national responses, we know that MSM need to flow efficiently, consistently, and sustainably through the entire HIV continuum of prevention, care, and treatment services, through education, self-testing, treatment as prevention, PrEP, and also distribution of condoms. And we know that several international funding programs, as the PEPFAR and the Global Funds, have economically supported the LAC countries, and also have helped in launching specific initiatives in partnership with national institutions, mainly the Ministry of Health of each countries, and also some of the regional institutions such as PENCAP and also CARFA. In efforts to reach the ambitious 95 goals of the UNAIDS by 2030, MSM are a high priority. And then we have recorded also a strong presence of civil society, organizations, and community-led networks is also noticed at the region, with civil society instrumental in both the region's HIV response and also human rights activisms. The PAHO has also advocated many times for combination preventions programs and right evidence and community-based programs that promote a combination of biomedical, behavioral, and also structural interventions. And many of the countries in these regions have also worked towards that pathway. I'm thinking about some countries like Haiti, specifically at the guest care centers. Unfortunately, there are some challenges that are still persistent despite the efforts. One of them is the conservative nature of the region, of the societies, that make it difficult to identify, define, and reach MSM groups, especially in small communities. And also, we are dealing with limited availability of data, particularly in smaller countries. And this challenge also is reinforced by the mobility that we are experiencing in the region. And there is little data on HIV prevalence among migrant and mobile populations. There are no collection or reporting of data for subgroups of stigmatized and isolated population who often face multiple and overlapping vulnerabilities and risk. There are some barriers to testing. They are still numerous, mainly linked to stigma, and also have access to care due to economic reason. Some of the countries, particularly the Anglophone Caribbean, has maintained some of the most aggressive anti-homosexuals laws. And even in Haiti, they have also voted a law to prohibit gay marriage. This reinforces also the stigma among the MSM communities. Weakness in health systems continue to present barriers to access and sustainability of services, particularly where parallel service delivery systems for HIV have been established. Other problems also include intra and interregional migration, as we know that the South America region is a route for migration through North America, specifically the United States and Canada, and including also high level of transnational mobility and return migration. This is a true challenge. Many countries continue to face deficiencies in research capacity and in translating findings into actionable recommendation for policy and program development. Vulnerability resulting from the lack of economic diversity and heavy reliance on international funders and donors for HIV program also is compounded by limited in-country institutional capacities. And we have also some consideration during COVID-19 pandemic with the limitation of movement and also that reinforce stigmatization and discrimination towards sexual minorities. We have saw the regional and then also the in-country responses. We have also analyzed the challenges that the countries in the region are still facing. And we can say that in the pandemic era, restrictions on the rights to personal freedom and security can only be imposed in limited situations. And we have experienced this through the world. And this must meet clear and strict guidelines in accordance with international human rights standards. And this is also specifically true for the region. The Latin America and the Caribbean region must now strike a balance between responding directly to the COVID-19 pandemic while dealing with vaccination and also potential new variants and maintaining essential health services at national, at regional, and local levels. I know there is a strong partnerships between the institutions in the regions. And finally, to end the AIDS epidemic by 2030, the global community will need to defy expectations in terms of tolerance and solidarity. MSM, as we know, can no longer be kept unchecked in the era of the Sustainable Development Goals with the motto, leave no one behind, while working towards a world free of HIV. Thank you very much. Merci beaucoup. Muchas gracias.
Muy bien. Muchísimas gracias,
Well,
doctor.
thank you very much, Dr. Dunbar, for your wonderful presentation. And now, continue with our third session in the symposium. I will give my presentation. I am currently the director of the Institute of Tropical Medicine and Global Health at the University, Ibero-American University. I'm also a full professor of the chair of tropical medicine at this university. I'm also a deputy professor at Michigan State University. I used to be a member of the emergency committee for COVID-19 in the Dominican Republic, and I am currently a physician, a microbiologist. I have a fellowship degree in infectious diseases from the Presbyterian Hospital in New York. And today, I'm going to talk about regional perspectives, focusing on key populations in the Dominican Republic. I'll go to my slides now. To my presentation. Good afternoon. I welcome all the members of this panel and all the participants to the API Congress. And I would like to thank the organizing committee for inviting me to participate in this panel that has been organized by the IAS through its educational fund. I'm going to talk about key populations in the Dominican Republic. The Dominican Republic has gone through a stable pandemic in the last few years. There has been a concentration basically in high-risk populations. The percentages of positive people, HIV positives among HSH, male drug sex workers and drug users. If we talk about specific populations, HSH and the trans population, and among the trans population, the figures are much higher. When you look at the breakdown, it is estimated that by 2019, 72,000 people were living with HIV in the Dominican Republic. This is 0.9%. When we consider other populations, which are also high-risk groups, we have women, uneducated women, migrants living in bateches, special settlements around sugar mills. They used to be in urban areas, in rural areas, and nowadays they have become urbanized. So they're in urban areas with high population densities. Therefore, the number of cases is increasing. The trends, according to the spectrum, well, the curve has become a flat line, so to say, with new people being diagnosed every day. So the pandemic is stable, and of course the death rates have decreased. However, when we break down considering different populations, we can see that the rates change regarding new infections from the general point of view. When we talk about HSH and transgender women and migrants, these are the populations where there has been an increase in the number of positive cases. So the access to HIV diagnosis through rapid tests has increased the number of people that can be reached. Antiretrovirals are given out for free, and this has changed the trends positively. And of course, in the prevention of vertical transmission, which is still important and high in our country, though the figures have dropped. The prevention tools such as PrEP and post-exposure prophylaxis are also provided for free by the healthcare system. So these are innovative prevention tools, and I'm going to mention them later on. And PrEP, well, in 2017, a pilot was carried out in an area or in a clinic providing comprehensive care in Santo Domingo. It was focused on HSH and transgender women. We worked with 271 people. The percentage of acceptability was quite good among transgender women and a little bit lower among HSH. So in the case of, in the baseline, the syphilis cases were quite high. However, after 12 months of follow-up, there were only 2% of new syphilis diagnoses. The coverage at the very beginning was only 12% in the case of hepatitis B, but however, 100% of the participants were vaccinated by the end of the study. So this was a comprehensive strategy focused on the populations that would be invited or attracted through more attractive elements and tools. The educational prep materials were developed using the language the population is used to, through resources that could be easily understood too. And of course, the result of this was the development of a national strategy to implement PrEP in the Dominican Republic. This was launched last year. It was a huge achievement because it was the first Spanish-speaking country in the Caribbean that had national guidelines for the deployment of PrEP. So by 2021, despite the COVID-19 pandemic, which delayed all everything, the number of users that were going to get to the services dropped by 25%, but in 2021, the figures began to grow again. So we increased the number of PrEP treatments given. Today, we have 11 sites which are active offering PrEP to users. And this program works smoothly because the Ministry of Public Health has the drug available and the sites, and through the services and through the National Health Service gives the healthcare centers and professionals the necessary tools to implement this program. What happens with the continuum of care? Well, over 100% of the people who already have a diagnosis, these are estimates, of course, they should be reviewed because there might be some overlapping, but it's interesting to see that 100% of the cases of the people living with HIV have entered the healthcare system. These are figures for 2019. We should review them for 2021, but this is the official information about the continuum of care. About the 100% of participants, 88% started antiretroviral treatment, 65% had a viral load, achieved a non-detectable viral load. There are two elements we need to cover to get to the 90-90-90 goals in the case of antiretroviral supply and viral load. These two elements, which are closely related. One relates to the willingness of the population to start treatment and to continue under follow-up. And number two, the availability of tests. Last year, there were some issues because the central laboratory last year became a diagnosis laboratory for COVID-19. So this had an impact on the supply of PCR services for HIV. And if we don't have the data, there will be a gap. It doesn't mean because the patient who is taking the drugs may not be undetectable. The point is that we are not measuring the viral load. Between 2010 and 2017, the percentage of children born with HIV has dropped from 14 to 10%. The number of positive women who received antiretrovirals during pregnancy went up from 41 to 87%. We implemented PrEP or treatment for everybody. And of course, we are working on the campaign of U equals U to keep on giving empowerment tools to the population so that they are able to benefit from the strategies we are carrying out in the country. And following suit of the global HIV strategies, we still have to cover or solve the issues of strategies to prevent stigma and discrimination. We still have to work on the issue of the centralization of services, such as molecular tests. We still have to work on keeping the sites that are already operating open and operating continuously. And in closing, a message which I found a couple of days ago in one of IAS web pages that describes how COVID-19 has impacted the response to the HIV pandemic. We have been fighting HIV for 40 years, but from success stories and failures, we have learned that we cannot overcome the pandemic unless we do away with inequalities, promote people-centered strategies based on people's rights, and work jointly with the communities to reach all those who need it. Winnie Beyanima used this statement as her closing remarks. And I would say that the Dominican Republic has to work on universal services to make sure that the venues build trust among all the key populations. Thank you very much, and I will answer any questions when the Q&A session starts.
Es para mí, como parte del programa, continuar e introducir a un gran amigo, a Ivan Cruz.
Continuing with our program, it's my pleasure to introduce a friend of mine, Ivan Cruikshank, who is a policy and advocacy coordinator at the Caribbean Vulnerable Communities Coalition in the beautiful Jamaica. Ivan will be presenting on teens, adolescents, and access to treatment and awareness of preventive methods in the Latin American and the Caribbean region. Ivan, very welcome.
Participated.
Él no está hablando.
Are you hearing me now?
Now it is.
Excellent. All right. Thank you very much, Paulino, and thank you very much, guys. I'm quite excited to be part of this panel to talk a little bit about the access to treatment and awareness of prevention methods in Latin America and the Caribbean. And I'm going to focus specifically on the Caribbean. Just to tell you a little bit about myself, as Paulina said, I'm Ivan Cruikshank. I work with Caribbean Vulnerable Communities Coalition, a regional coalition of NGOs here based in Jamaica, but operating across the Caribbean. I previously worked at the University of the West Indies. I'm a policy specialist. And so part of what I tend to do, and part of my work, is to look at these issues from a policy perspective. I also currently chair the country coordinating mechanism here in Jamaica. So I want to start out by just giving a little bit about some background issues that we would want to look at as we engage with this particular topic. Okay. I find that, okay, I'm going too fast. Okay, great. All right, great. Okay, quick. That's better. All right, good. So a couple of observations. Adolescents, and the presentation is focusing on teens, but one of the issues that we have found is that there's very limited data on teens specifically. So we have used adolescents as a proxy for our conversation around teens. And adolescents between 10 and 19 comprise about 9 to 12% of the populations of the Caribbean. And here we are talking about the English-speaking Caribbean, Cuba, Dominican Republic, and the overseas territories that are aligned to CARICOM. The other observation that we note is that the sub-region has the highest incidence of HIV/AIDS outside of Africa. which tells you something about our prevention, intervention, and the need for accessing treatment and prevention services. Young people, including adolescents, based on the data, are at the epicenter of the HIV epidemic in the region. And we know from the data that key population youth are at a higher risk for HIV and are indeed a higher risk group among these young people or these adolescents. We also, as a proxy for what is happening, look at the adolescent fertility rates in the region, and they are indeed the second highest in the world at around 60.2 per 1,000. In respect of prevention, what we note is that health and family life education act as the entry point for HIV prevention and indeed broader comprehensive sexuality education. So we need to interrogate that a little bit more. There are a number of factors that predispose teens to high-risk sexual behavior, and we see them noted there. We have poverty, we have youth unemployment, drug, alcohol abuse, violence, and gender equality. These are all things that, as part of the prevention response, we need to engage with. Across the region, parental consent remains key to providing services to adolescents that are 16 years or under. And there's limited information on adolescent services available across the region. So that's a challenge in terms of just our understanding of what is happening with our teens. So this is just to give you a sense of what the adolescent's birth rate is across a number of the countries. And you'll see as high as 90 in Guyana, down to a low of about 30 something in Bahamas and Grenada. So it tells you that it is almost consistent across the Caribbean. We have significantly high adolescent birth rates. So as we talk a little bit about access for teens, I want to sort of anchor the discussion around access to selected treatment and prevention interventions. I try to break this up into 3 types of interventions. One is HIV-specific adolescent interventions. The other, looking at cross-sectoral interventions. And then we want to look a little bit around how adolescents are represented in regional and national coordinating mechanisms and responses to support their own access to services. So if we take the area around HIV testing, treatment, and care, which would include psychosocial support, a number of issues confront us. One is that we note from the data that young people, adolescents, do not have consistent quality access to HIV testing services. And that is compounded by a number of variables. And some of those variables are impacted by some of the social and cultural norms that exist in the region around sexuality and young people's sexual health and how those actually should be treated. There is a very conservative context operating within the Caribbean that discourage well-established interventions for teens, adolescents, and young people generally. So what you find is that wherever those services have to be provided, invariably they're tied to parental consent and limitations on how service providers can engage with young people. There are also questions around values and expectations from family, peers, teachers, etc., related to sexuality, pregnancy, and violence, which are also impacting how young people, in particular teens, can access HIV-specific interventions. We also note from the limited data that we have is that the information, limited information and restricted access do relate or correlate closely with the incidence of teenage pregnancy that we see. So we recognize immediately that there is a problem that manifests itself in the level of teenage pregnancy that we note across the Caribbean. So in terms of information, the data is showing us that 1 out of 3 young persons aged 15 to 24 are inadequately informed or unaware of ways to prevent HIV. And that is data that is coming out of UNFPA. And it shows that somewhere between 43% among girls are aware and 42% among boys have an awareness. In fact, the KAPB in Jamaica in 2017 shows that just about a third of adolescents between 15 and 19 were able to identify correct methods of HIV prevention while rejecting major misconceptions. So in terms of just access to prevention information, we recognize immediately that we have quite a big challenge on our hands. The other thing that we note across the Caribbean in terms of just having access to combination prevention is that the interventions tend to focus largely around abstinence and being faithful, which is what we call the ABC concept. And while those concepts are useful, we know that those are insufficient to adequately address the needs of our populations. So if we look, I want to focus now a little bit around some of the fundamental barriers that impact our HIV treatment and prevention responses. The first, as I mentioned earlier on, is the conservative environment. The other one is that many countries do not see teens, especially those living with HIV, as key population for HIV intervention. That's a major challenge that needs to be responded to. The other issue that we note is that a lot of our regional and national responses continue to be undermined by laws and policies which limit access to prevention services, and indeed some which criminalize sexually active adolescents and service providers. So one of the big areas that we note in the response is that the gap between the age of consent, sexual consent, which is 16 years across most of the Caribbean countries, and the age at which teens can independently access service creates a significant challenge. The other issue that we note is that comprehensive sexuality education, when it is proffered, is often conflated with the LGBT agenda, and that creates obstacle to implementing CSC and indeed HFLE to scale. Most of the countries in the Caribbean lack differentiated models of treatment and care for adolescents. So what you do find is that adolescents and teenagers are expected to access services similar to what adults were. And we know from a number of studies that their behavioral patterns do not lend themselves to those same type of models of intervention. We also know that the sexual and reproductive health services are not successfully engaging with adolescents that are particularly living with HIV. So that's an issue that confronts us as a region. I think the final thing that I want to raise here is just look a little bit around what are some of the areas that we need to address. I think there needs to be some significant reviews of the laws and policies that limit access to SRH services for young people. In particular, there needs to be revision to allow for access to services by competent minors using particularly competencies like the Gillick principle, or what needs to happen is that where healthcare providers deem it necessary to provide services, there needs to be some protection for healthcare providers who are providing services for young people. There is need for scaling up of age-appropriate health and social interventions that go beyond HIV, which are linked to community-based venues which are acceptable to and frequented by adolescents. A lot of times, adolescents are expected to come to services that are within health facilities and that pose a problem for access. There's a glaring need to scale up access to comprehensive HIV treatment programs for adolescents living with HIV. Another area that we recognize that there's a need is to develop and roll out sex and health positive messaging using new technologies and approaches so that young people begin to feel comfortable and confident about sexual discussions, sexual issues, and engage with those issues. And the final thing is the need to strengthen participative capacity of adolescents to be able to engage with national HIV responses so that they can become part of national strategic planning processes and developing interventions which are ideal to their own circumstances. So those are some of the areas that I want to put on the table, and we can have some further discussion in the question and answer session. All right, thank you. Over to you, Paulina.
Muchísimas gracias,
Thank
Iván,
you very much, Ivan, for this wonderful presentation. Now we will tackle the questions. But you participants may write your questions in the chat box so that we can start the Q&A session. We will start with a question for Willie Dunbar. There's a question here. Could you please share with us some more detailed information to explain why stigma and discrimination have increased during the COVID-19 pandemic, especially among LGBT populations, and whether there are any cases you have seen, whether you see what has increased the stigma related to MSM and other populations in recent times.
Thank you very much for the question.
Gracias por la pregunta.
As I presented, LGBT community is always stigmatized and discriminated when it comes to something bad happening in their region or in their countries. Specifically in Haiti, I don't know if you can remember, in 2010, we have experienced a major earthquake. One of the observations that we have seen is the population, the general population, have started to blame the LGBT community for that, as it is a punishment of God for sins. So we are experiencing the same thing here during the pandemic, and this is an observation that I have made during my doctoral research in Haiti, and also through discussions. I noticed that through the discussions with some colleagues in other countries in the Caribbean and in Latin America. So this is one of the reasons, as the LGBT community and the men who have sex with men are always discriminated, they are also taken into account when it comes to disasters in a particular country and a particular community. So thank you for the question. I think there was a second part of the question that I didn't catch. Could you please repeat?
Sí, habría.
Yes. whether you have been able to find out any specific case, situation, or element which might have triggered the increase in stigma related to MSM, related to them, or something that has happened during the pandemic.
Yes, exactly. As I said before, I explained the situation, but one of the situation that I've noticed, and during my interview, some MSM have also reported that they are discriminated in their own family. And as you know, there was a lockdown in some of the countries. So this situation forced people to live at home, to stay at home, and also reinforce violence and interactions with member of the families and also member of the communities that are discriminated. So this situation, this lockdown, is one particular situation that I can take as an example to illustrate the increase of discrimination among MSM communities. Thank you.
Iván, a propósito
Ivan,
de lo que mencionaba Willy,
regarding what Willy said about MSM during the lockdown, do you believe that do you think there are any elements that have struck us among adolescents? Schools are closed. In the Dominican Republic, for example, children and adolescents have been going to school for 18 months, and this is something which increases their vulnerability, the vulnerability of these populations. Could you elaborate on this?
Yes. So I think the biggest issue that we have found among adolescents is the issue increase in gender-based violence. So a number of assessments have been done across the Caribbean, which have shown that during the lockdown, issues around gender-based violence as a significant issue, developed as a significant issue. The other thing that we have found beyond gender-based violence is the issue around addressing their mental health needs. Because a lot of the adolescents and the young people, their space where they get to engage, and that point of release is the school environment. It's not the home, because the home, many of the homes are toxic environment. And so what you have found is that the inability of these young people to be able to go out and engage with their peers creates a significant challenge. The other thing that we have also found is that where they have parents who themselves are pressured by the context of having to stay home, they take it out on the children. So you find that a lot of, sort of violence is being perpetuated, and some of it is not physical, it may be verbal violence being perpetuated against the adolescents within the context of COVID. So that is what the data is showing us. I'm not sure that there's much around stigma, particularly at the general level. We do know that for key population adolescents, the same concerns that were raised by Willie exist among the key population adolescents.
muy bien. A propósito,
Great. And in this session, we have Mayra Rodriguez from COIN. She wasn't able to share her presentation because of some technical issues, but as you are here, Mayra, from your point of view, the point of view of mental health, in your practice, have you seen anything that might be related to an increase of rejections, especially talking about transgender women in the Dominican Republic, something that has gotten worse because of the pandemic? Good afternoon. Thank you very much to the organizing committee and you for giving me the floor. We have seen three basic elements related to the pandemic, which has increased stigma and discrimination, especially among transgender women. First, the fact that they have to live with their relatives and families during the lockdown, so the relationships among the families became a more tense situation. And from the point of view of the online sessions during the pandemic and live sessions after the pandemic, we realized there was an increase in violence, gender-based violence, especially within couples. Besides, we have the economic situation. Many transgender women live on or are sex workers, so as they weren't able to leave their homes, they weren't able to earn a living, they weren't able to work. Thus, there was an increase in stigma because there were many job offices where they were not offered a job on equal standing as other people of the population. So we need guidelines that protect transgender people, because we don't have the gender identity law in our country, and we don't have any law that protects people if they have a different sexual orientation. So this affected the mental health of many people, especially of those who have, and especially among people who have certain religious beliefs. They are against these key populations. So there is so much violence within the couples. Therefore, in families and in society, we see higher rejection rates. There is also more vulnerability. And from the point of view of health and HIV, well, we know that because of all these reasons, there are more dropouts from the continuum of care. So we have had to work hard with civil society organizations in order to work to empower these populations so that they may exercise their rights. A lot has been done in this respect, but as you have already said, we still have a long way to go in the area of public policies so that the venues become friendly and welcoming. I know that COIN, the site or the hospital where you work, has done a lot in advocacy terms related to human rights of these populations. Do you think that that work or those activities have increased during the pandemic? I know this is a cross-cutting issue related to the rights and to the health of people. Well, this is very interesting because we are carrying out advocacy actions. We continued doing advocacy at the Observatory of Human Rights, which is part of COIN. We are working on this too. We provide training to the judiciary, to healthcare staff on legal issues too, so that they take into account public policies. And we have also been working with LGBT groups, and through their work, they have helped create awareness to reduce stigma and discrimination, because this is a road along which we have been moving for several years, but this is a work that has to continue forever after, because once we have trained a group of people, they leave and we have to start from scratch training new participants, new stakeholders. We have to work with all hospitals and care centers to do away with stigma and discrimination. This is not only health, this is stigma and discrimination. So we need people who are properly trained, and we need the people who need those services to know about their rights. In the area of PrEP, which was mentioned, we know that although it is widely used, it was a difficult goal to reach because we had to work together with the civil society so that people would come to the healthcare centers. And nowadays, in the case of PrEP, there is more demand than supply, actually. Yeah. And if I have to summarize, I would mention violence, conflicts in families, in couples, and lack of employment and lack of income. And we still need to empower society so that these populations, so that they become aware of their rights. And in closing, I would say that at COIN, we have worked a lot with the families, and we have achieved good results in terms of reducing discrimination. What we have done is not enough because of our limited resources, though, but this should be extended to other organizations, healthcare organizations, or civil society organizations.
And talking about families, one of the things we've discussed thoroughly in terms of approaching populations which are difficult to access is the possibility of implementing self-testing pilot programs. Maybe Willie and Ivan can answer this question. Do you think that teens and MSM populations are aware of the self-testing possibility? Do you think they think of that as a tool that will help them get an timely HIV result? Do you think that there are still barriers in our countries, especially in Latin America and the Caribbean, that may be a hindrance to the possibility of implementing these tools? First, Ivan, and then Willie, please.
Yes, thank you for that question. So I think the possibilities exist.
¿Se frizó?
Está frisado.
I
Sí.
think his connection is lost. Willie, maybe you can answer.
Sure. In terms of self-testing, I know the pilot program
Opportunity once the information
helps.
No, I'm saying that. So yeah. So
Okay,
there is
muy bien.
yeah. So I'm saying that
Te escuchamos, Ivan.
Okay, go ahead, Ivan.
I was just saying that there's a possibility to roll out pilot programs for groups 17 to 19. And indeed, there is right now in one or two countries that they're actually rolling out pilot programs among selected groups. And I think adolescents 17 to 19 can be included in those groups.
I would add on that in terms of barriers, there are availability problems in some of the countries, and sometimes in the same countries in terms of regional availabilities of self-tests. But also the major problems that we are facing in this is the education and then the counseling of this part of the population most affected by HIV. Because if they are not educated and counseled about the self-test, it's difficult for them to engage in search prevention. The second thing is to consider also is after the test. So because sometimes during the research that we have conducted, it's sometimes stressful for them to know their HIV test result. with the self-test, this would be a good opportunity for them to know their status, but the problem still persists after. What can they do about the result? So I think the major problems refer us also to the education and counseling situation, and at another level is to conduct training for healthcare providers and also community workers. So because the community workers specifically, they can reach easily the community, and also some peer navigators and peer educators, so they can attract them to the self-test and give them a chance, a way to have treatment after the test. Thank you.
Sí, definitivamente la importancia
Definitely,
dentro de estas estrategias está centrada
in
justamente
terms of these
en involucrar a las
strategies, what is really
comunidades a
important
través
is to
de
engage
actualizar lo
communities.
importante.
I think you have
Creo
pointed
que
out this very clearly,
punto central
and I think
de
that
nuestra
is
sesión del día
key
de hoy. No tenemos más
in terms of our
preguntas
session today. There are
por el
no more
momento.
questions for
La verdad es que
now.
le agradezco mucho a
I'd
Mayra,
really like to
Iván
thank
y Luis
Myra, Ivan, and
sus
Willie
maravillosas intervenciones.
for their
Con esto
outstanding
vamos a
presentations.
concluir este
We will
simposio.
now conclude this
Quiero agradecerles
symposium.
mucho a
I'd
ustedes
like
por
to
su
thank
tiempo
you
y
all
su
again for your
participación.
time and your
Quiero dar las gracias
participation.
a todos los
I'd also like to
participantes
thank
que
all
pudieron estar con
participants,
nosotros
all
el día de
speakers,
hoy
and everyone
desde nuestra
who
región,
has been with
obviamente,
us,
y que
people from our region, obviously,
obviamente que haya
and
sido de interés
we hope that
para
this
cada uno de
has
ustedes
been
y que les
an
sirva
interesting
en su día a
session to
día
you and that it
diario.
will
Creo que
help
con
you in
esta
your everyday
información
practice.
dejamos algunos
We
mensajes
hope that
para casas, algunas ideas
we will
nuevas
all be
y tal vez
taking new
soluciones
information and
que
ideas
puedan
with us, as well as
adaptarse a los
solutions
grandes retos que tenemos
that
cada día
we
en nuestros
can
países y
have
algunas ideas
to
también
face the
que podrían
challenges we see in our
consultarnos
countries. And I
en
hope we will
los
also
últimos
get new
conocimientos que hemos
ideas
recibido a través de
about
este último año
the
y que
latest
puedan implementar a
knowledge
nivel
that has
regional
been developed over the
y que
last year. And I
sirva
hope this
también
will
obviamente
be,
para
that we will
fortalecer
be able to implement this in our
una
region, and hope this
colaboración
will help us to
en las
strengthen
políticas públicas
cooperation
en la práctica
networks
del
in
VIH.
public policies
Además
and
también,
HIV
obviamente,
practices.
como todo esto repercute
Obviously,
en mejorar las
I
políticas,
hope this will
las
lead to an
prácticas que
improvement in
actualmente
policies and
están
practices
implantando a
that are
nuestra región y que
currently
son
in place in our
responsabilidad de cada uno
region.
de nosotros
And it
que
is
generamos
our
advocacia
responsibility,
para
those of
que
us who do
cambien las
advocacy
realidades de
work,
nuestra
to do
población.
something for these
Con
realities
esto,
to change.
quiero también aprovechar a los
I'd just like to
participantes del
take
día de hoy
advantage of
a
this
compartir
opportunity
las grabaciones de las secciones del día de hoy
to
con
tell
sus
you that we will
colegas
be sharing the
que no
recordings
pudieron
of
estar
today's
con nosotros
sessions.
en vivo
So please
van a
share
estar
the recordings with your
disponibles a través
colleagues
de
who were
la
not able
cuenta
to participate with
de
us
IAS
live.
Educational Fund
The recordings will be
IES
available
y pueden
soon on
también
the IAS
buscarlo y
Educational Fund
compartirlo
platform.
con sus
And please make
grupos de
sure to share
trabajo.
this with
Quiero dar
your
las gracias al
colleagues.
equipo de
I'd like to
Guestio
thank the
por
Guestio
toda la
team
ayuda que nos han dado
for
en la
their
realización del programa
support
de
and
este symposium,
contribution
también al
to this
equipo
symposium's
maravilloso
program. I'd also like
de
to thank the
educación Fund IES
wonderful
que nos ha dado
IAS
tanto
Educational
ayuda
Fund
y también
team
al equipo del
and
Congreso de API por tratar
the
de ponernos a
API
todos el día
Congress
de hoy
team. I'd like to
juntos
thank
en
you
esta sesión.
all for having
Pueden
organized this
también,
session.
si tienen alguna pregunta,
If you have any
acceder al equipo
questions,
de
you
membresía de la
can get
sociedad de VIH.
in
Quiero,
touch with the
por último,
IAS membership
recordar a
team.
que
Finally,
participen
I'd
en la
like to
evaluación
remind you
que les va a
to
llegar
fill in the
inmediatamente por correo
survey
electrónico al final del
that you will
día
get over
y
email by the
también,
end of the
obviamente,
day.
recuerden que con
And
esto pueden
remember
solicitar su
that by
membresía a la
participating,
sociedad
you will be
si
able to
están
request
interesados en ser
your
parte
IAS
de la familia
membership
de IAS.
if you're interested in
Muchísimas
being
gracias
part of
a
the
cada
IAS
uno de
family.
ustedes.
Thank you
Espero que
all.
estén bien en sus casas
I
y que aquellos
hope
que no
you're
están
safe at
puedan retornar a las
home.
mismas de
And if you're not
buena
at home, I
manera.
hope you will be able
Muchísimas
to go back
gracias.
home safely. Thank you all.